Good afternoon, everybody. This is Dean Goldman. I'm going to be starting in just a moment. Still watching that some people are continuing to log on, but we will plan to start in just a couple of minutes. Thank you. Okay, I think we're going to go ahead and get started. Good afternoon, everyone. If that happens to be the time of day for you where you are now, or good morning or good evening, depending on where you are in the world. But it's wonderful to have you able to join us today. I wanted to give another briefing. We're starting to do this every week. I think that starting next week, I may sometimes have guests online with me. Just want to do a sound check with Jonna. Are we okay for sound?
You're good to go.
Thank you so much. All right, so without further ado, I want to just start by giving a little bit of an update about how things are going with the school for those of you who are interested in that. As you know, this is our second week of exclusively online teaching, and that I think, had a heroic effort by our faculty to make that switch mid-semester from teaching in the classroom to teaching online. That is not easy. Some of them have experience with online teaching, have been part of the 2U program. Some of them had not, and they've all been quite willing to put the extra effort in to make it happen. I know that a survey went out to members of the community about the experience, both for the faculty and the students, and I would appreciate it if those of you who are on the line, if you have not responded to the survey, to respond, because it's going to be very, very helpful to us in terms of understanding what the best approaches are and whether we need to make any mid-course corrections in terms of providing a better experience. So but I will say the school is lonely without all of you being there, and I look forward to the day when the whole community is back together. Next slide. So again, talking about a little bit about the SARS virus, the COVID-19 disease, of course, is caused by the SARS-2 virus, which is somewhat different than influenza. Next slide. And so if we can have of course, thing to remember, and I think we're all aware of as public health people, is that in essence, the virus is spread through coughing, and it's also can be spread through speech, and then subsequent transfer of the virus via hands to your face, fomites, objects in the environment, and so forth. Next slide. So the last time I talked a little bit about how these viruses are the same and different. This virus is certainly a sticky virus that can be hidden for days and hours. And in the environment, it's quite deadly, and we don't have a vaccine for it. Next slide. So what we try to do to control the virus in the absence of a drug to treat it or a vaccine is to flatten the curve. And you're all aware, I know, of the statistical models that have been done to help to guide us to try to keep the numbers of cases below the level of our healthcare system's capacity, because we know when we exceed the capacity of the healthcare system, that is putting everybody at risk, not just people with the COVID-19 disease, but people with any illness that would cause them to have to be treated in a hospital. Next slide. And these slides are looking a little different than the ones that I thought I was going to be using for this presentation. Jana, should I take over with, I hate to do this in the middle, but um, can you go one more forward and see what we have? Yeah. So this is a different presentation, and I am going to, I think, pull up the presentation that I want to use and try to take over the screen if that's okay. And I apologize for that. We probably should have run through them to make sure that we had the perfect communication about which was which. So let's see. So I am going to put before you what I think is a very messy looking screen. Hopefully it's coming up for you. And that will have the current presentation that I actually want to use. And okay, so, and can you still hear me, Jana?
Yes, we can still hear you.
Okay, so this time around, I wanted to talk a little bit about, because we're hearing about in the news all the time, the issue of modeling and how it is that these models are done that you're hearing about on the news from uh, uh, from Dr. Birx, who's running the pandemic response, from Dr. Fauci, from the press. And those of you who have particularly been interested in communicable disease epidemiology know that there's this important parameter called R naught, which is applied to an infectious disease and describes how communicable it is. And that's a very important parameter. The incubation period is important, the time course of infection, at how long people are actually infective, and a lot of unknown parameters, such as how long people are immune after an infection, how well the actions that are being taken to get us to stay at home and flatten the curve are actually working. And then factors like population density and the size of our households and how many precautions we really use. And as we're learning, also the stability of the virus in air and on surfaces. All of these are important factors in terms of um, how the R naught and how well the virus is able to reproduce itself. And I was, as was in the other presentation, it isn't just one wave, it's probably going to be more than one wave, as we saw with the 1918 flu pandemic. And so we also have to be thinking about that. So something that we're hearing a lot about in some other models that I wanted to show you, um, there's in Seattle, associated with University of Washington, a group called the Institute for Health Metrics Evaluation. And they've been doing health services research to try to compare the amount of services we have available with the projected numbers of cases. So for example, for Washington, D.C., that top purple line is how many hospital beds the district has. And the dotted purple line is the projection for how many beds will be needed on any given day between now and the theoretical end of the epidemic, the first wave of the epidemic in DC. But the shaded purple line shows the confidence intervals around that, which do, go potentially over the available number of resources. But what's really of concern in DC, and people are working on very hard today, is that there may not be enough ICU beds. There are enough hospital beds, probably, according to these models, but we have 66 ICU beds available and 134 needed. Now, I know that everybody's working hard to create more ICU beds, and that there will probably be more by the time things really hit their peak. According to this model, DC will peak on April 16th, 2020 in terms of medical resources, and they're projecting 220 deaths by early August, which is quite a number for a town just of our size. On the other hand, Maryland has a more severe problem with a shortage of beds that are available, as well as ICU beds. And of course, it's a larger state, it's a larger population. Their epidemic seems to be following behind DC's by 2 weeks, according to this model. So more like April 28th, that we'll see the peak use projected deaths of 1,691, unless more things are done to try to prevent these deaths. And so, as you can imagine, the work is underway in Maryland to try to strengthen that, but it isn't a lot of time for advanced planning. And then in Virginia, where there have been more delays in terms of putting in place tougher measures to enforce staying at home and social distancing, the peak is thought, according to the model, to be occurring a little bit even later in late May, going all the way, as you can see, the major episode, into early July, and that they do seem to have not enough ICU beds, even when they have enough hospital beds, similar to DC. And I know that the hospitals in the region are involved in some very intense discussions with Homeland Security and public health to try to figure out, are there ways to be able to mutually assist each other in order to be able to take care of some of these things. Just as our hospital at GW is looking at all kinds of options, for example, perhaps that births could be done in a different facility than the one that's needed to treat the COVID-19 cases. So for the country as a whole, this model, which is somewhat different than some of the other models, but this model actually puts in the actions that have already been taken by governments to try to enforce social distancing, but it's still a lot of deaths. I mean, you've heard things on the news, 100 to 200,000. Well, 93,765 is not far from 100. And there is a huge amount of uncertainty around these estimates. But that in general, for the entire country, that there seems to be a likelihood that we're hitting a peak somewhere in April, but that there's this long shoulder on the other end as the epidemic is spreading into various regions of the country. So you can actually go on to this website and look state by state. Unfortunately, they don't break it down into smaller levels. And every day, these projections change because as actions are taken to enforce social distancing or to develop more ICU beds, more hospital beds, bring in more ventilators, the picture changes. This is not a static picture at all. And I do think that there's a lot of uncertainty in this. And I would not take these numbers as being real numbers. They are model numbers. But I think they do help us to plan, and they help us to understand what the challenge is. Because here we are, we're in April, and we're already seeing the beginnings of all of this up in New York and New Jersey. And so we're taking this very seriously. So I read some things this week that I thought you might find interesting. I just want to share them with you, and then we can take questions. But one is something that the CDC published yesterday about pre-symptomatic transmission, meaning before somebody has symptoms in it, but this is someone who develops symptoms, that there are a couple of days, it seems, over which that it is possible for them to be transmitting virus. And they are hypothesizing this might be via speech and other vocal activities, or that somehow people are contaminating fomites. So social distancing is important in this epidemic, even when somebody doesn't have symptoms. Don't assume because somebody is symptom free that it's safe to be within 6 feet of them is kind of the take home message from this. And so I think it's a very important study. Um, so the hypothesis that this might have to do with speaking. And in fact, they cited this paper. I thought I'd share this with you too. And that is that actually, when we speak, we do emit a lot of particles. We um, aerosols, the smaller ones, but also larger particles. And that, so what this graph is showing you is the numbers of particles and then by particle size, but the particle size is on a log scale. And whether you're speaking loudly at an intermediate level or quietly makes a big difference. If you're speaking loudly, you emit more particles. And I think some of us have had the experience of actually spraying or seeing people spray when they are speaking with emphasis, right? And it does help explain why in the early stage of this outbreak in Seattle, that a church choir member who'd become infected and then attended a rehearsal with a few dozen people, several of them got the infection. Probably that was a really good singer, a loud singer who emitted a lot of these particles. The other thing that's interesting for some of you more environmentally um, prone people on the call is that some of these particles are very, very small particles. And that means that they can be inhaled as well as falling on surfaces and contaminating those surfaces. So if they fall on your face and then you kind of rub them into your nose or your eyes, then you can get infected. But if you inhale them also, if they go straight down into your lungs, that is a big risk for, I think, developing pneumonia from this disease. Also in the news, and it really came about largely because of this study showing a pre-symptomatic transmission, is that both CDC Director Redfield and the White House coordinator, Dr. Deborah Birx, are starting to talk about the possibility of a policy about the use of face masks by the general public. And so Redfield talked to the National Public Radio on Monday and said, a quarter of people who are infected remain asymptomatic, no symptoms at all. And we know that people without symptoms can be contributing to transmission from their MMWR report yesterday. I'm guessing Dr. Redfield knew that was coming. And so experts like Dr. Gottlieb, the former FDA commissioner, are starting to talk about face masks for the public as well. So according to the World Health Organization, you, a member of the public, only need a face mask under two situations. One, if you're infected and you're going out to get treatment and you want to wear that while you're going out. Or two, if you have an infected person who you're caring for, somebody who's sick, who cannot go, doesn't need to go to the hospital and can be cared for at home, they recommend that you wear a mask when you are taking care of that person. However, that guidance doesn't account for the fact that you can be contagious without symptoms and that the people that you're around could be contagious without symptoms. And so I think that's the reason why they're considering this. There are a lot of implementation issues, and we in public health are always interested in these. And one that's just very fundamental is that there's a shortage of medical grade masks as well as surgical masks for the actual healthcare workers. And we know that they're the first priority for protection because they need to be very close to people who are infected. And this is a behavioral issue that all PPE, but especially masks, can give people a false sense of security and can even serve as fomites, means of transmitting infections. And Dr. Santos Burgoa, who is on our faculty, told me a story about how in Mexico, when they had the H1N1 epidemic, the government sent masks to everybody without any other behavioral instructions, no context around that. And they thought they could just put on the masks and go out and do business as usual. And it caused a lot of spread of the flu because people were overconfident that the PPE itself would protect them. And we do know there's a lack of an awareness in the US about how to use masks. There's a lot of behavioral change and education that would have to go along with it. But I do think it's likely they will recommend wearing masks, maybe not the types that are essential for healthcare workers, just because of the practical reality that we don't have enough. And there is some evidence that even homemade masks, like cotton ones, um, can provide some effect. They're not as effective as the medical masks, but they nonetheless provide some effect in terms of protecting you from somebody else's, and certainly they help prevent you from spreading it. If you see what that cough looks like when you're coughing through a cloth mask, you're not going to see very much of that going out. So, the important messages that we in public health have to be pushing all the time, certainly social distancing, the decisions by government, we need to do those things. Stay at home. We've closed the schools. Many places are closing non-essential services. Everybody has not done that. I think restricting travel is a good idea. I've restricted my personal travel, but also that individuals need to make decisions that they will not congregate and they will stay a distance away from each other. And I think that you're all aware that there are places around the country where that message has been very slow to be absorbed by the public and by governments as well, and that they're probably going to suffer larger impacts from the epidemic as a result of that. In terms of hand hygiene, hand washing, hand sanitizers, do a really good hand wash, use the 70% alcohol sanitizers. Cough hygiene, cough into a tissue and throw it away or into a sleeve, but do not cough, right into the environment. Avoiding touching your face. And in my opinion, probably yes, masks. We probably will be getting used to the idea of using masks, but it's only in addition to the other four things. It's not instead of, because masks are just an extra layer of protection. They don't take the place of social distancing, hand hygiene, cough hygiene, and avoiding touching your face. Over time, there will be some immunity, but our scientists, I've had Dr. Cindy Liu has been working on this, and she, in her review of the literature to date, she doesn't think that the immunoglobulins that we naturally get after we've had this illness are going to last more than a year or so on average. So it isn't long-term immunity from having this once, and ultimately a vaccine, hopefully in the next year or two. And above all, to take care of yourselves and those around you, I think is a message that I want to leave you with. It's really hard being at home, and it's a real it would be a lot more fun to be able to go out and see our friends and do all the things um, that we'd like to do. It's important while we're at home to stay on a routine, stay on a normal schedule, eat well, get physical activity, and try to enjoy the time that you have with whoever you're sheltering with, whether it is your family, your friends, or yourself, and of course using social media to connect with each other, to reach out to your support networks is very important during this time. So I thank you, and I hope that we were able to make that happen. And I see if I can stop sharing my screen here. Let's see where that is.
We don't currently see your screen, so it's okay. You're good.
I stopped it. Well, that's a miracle. Thank you so much. I appreciate that. And I'm sorry about the confusion about which slides, but hopefully that was okay for you guys. So I think we have some time for questions. I think that there's a kind of a Q&A box. If you have any questions that you want to ask me about anything about the school and how it's going, or what we're doing at GW School of Public Health with the COVID-19, or any other thing that might be on your mind. Question: if you were writing letters to Congress, what would we ask for our healthcare workers in the national response? It's a very good question. They've just finished appropriating tons of money for all kinds of things that I think are important. There's a lot of money in there for the needed medical supplies. I think Congress is cognizant of the fact that we need more testing and we need ventilators and equipment and all of that. If you want to know what I'm most worried about, I'm very worried about people who work in jobs where they're not able to have continued income during this. Many of them may have trouble getting unemployment benefits because of if they're doing temp work, or they're doing the kinds of jobs where you don't get benefits. I'm worried that we're going to see a surge of homelessness in some of our communities because of the impact of all the things that we're doing to flatten the curve, that many of these non-essential businesses that have been shut down in places around the country employ people who are hourly wage workers who are living very close to the edge financially. And, so to make sure that there's help for them and their children, I think it's very important. I also would like to see Congress reconsidering the structural issues in our government around leadership of this for this kind of response. And because I think that what's happened in the last few weeks makes it very clear that there's some serious weaknesses that need to be addressed. And probably, just as we would want to do an after action report if this were a drill, and identify what all the weak links in the chain have been and how we address those in the future. I would hope that Congress and the White House would come together and do a major nonpartisan review of the entire epidemic and come up with some recommendations for the country of how we could address this better in the future. Thank you, Katie, for that question. Arena Moriarty, do I think there will be another wave in fall? What could this mean for classes? So I do think that it's very likely that COVID-19 will continue to circulate around after this big initial wave, and that we will not see the end of it until we have a vaccine or a cure. And I do think that has implications not only for fall, but for any time in the future until there's a vaccine or a cure, about how we operate. GW, I will tell you, it hasn't issued any formal announcements, but we really want to be able to bring our students back in fall. And I think if the DC Department of Health and the federal government says that Washington, DC is open for business, that we will want to bring our students back to DC. I've already been asked, how can we do that in a way that is safe for our students and where we can provide care for our students? And I think we can do that. I think that when I look at how South Korea has dealt with the COVID-19 through really traditional public health, communicable disease control methods that probably they learned from our own CDC. And that is that you do case identification, you do contact tracing, use testing to identify people who might be carrying the virus. And I think we could be much more selective when we have the tests in terms of how we do that. A piece of good news is that the School of Public Health has helped the hospital set up testing. We have testing now at GW, and we're working to set up testing in our own labs in the Science and Engineering Hall. I don't think that the testing shortage that we are seeing now will be a reality when it comes to fall, and that will help us a lot. The question about the national stockpile and who's in charge of it and when will it run out, how do we make sure that the states aren't competing against each other for supplies? So the national stockpile is, it's run out of the Department of Health and Human Services, and it, the whole thing won't run out, but there are items in the stockpile that are running low or that we're running out of. And so that's a problem. I think that to some extent, how the stockpile was created was predicated on a few assumptions that may not have been correct in terms of the probability of having such a massive episode as what we've had here. But, you know, I would say it's less that the states are competing against each other, although I realize that some of them feel that that's what's going on. I think the virus is determining where the stockpile goes. I hate to say it that way, that we were expecting some materials to come to DC a week or so ago, but because of the situation in New York, they had to be diverted to New York. And quite honestly, we in DC couldn't possibly say that that was wrong because of what's going on in New York right now. And I think we all have to realize it's in our national interest that whatever resources are available go to where the problem is worse and do what we can to quench that, because that will wind up being just a source of more difficulties for the rest of us. Um, but I know that also the federal government has other powers. I personally would like to see them much more engaged with getting the defense establishment to turn on more manufacturing for some of the vitally needed goods like face masks and ventilator parts, actually. Um, that's something that you haven't heard very much about, but yes, there's a shortage of ventilators, but also the little plastic fittings that you need, some of which are disposable items. Those things are really, really important. You can't operate the ventilator without them, and we're short of some of those. Uh, why does it affect people? So I think that yes, that there's a lot of research that is going to be important to do to understand why the disease is affecting people differentially. We do know that certain chronic diseases are setting people up for having more severe COVID-19. People who initially had diabetes or heart disease or chronic lung disease, certain neurological diseases are more susceptible, more likely to have serious version of COVID-19, more likely to die from COVID-19. Obesity is another condition that seems to be associated with severity. And actually, Dr. William Dietz on our faculty and Carlos Santos Borgoa wrote a little article that should already be actually in press in obesity about that I think is well worth reading. It is also true that we're beginning to see that just recovering from the disease and being well, in the sense of being able to be taken off of the ventilator and discharged from the hospital, is a lot of people are not coming back to full health at that point. They're being left with some kind of a chronic lung problem or some other problems. And so it could well be that we will see subsequent disability, people having a tendency to more respiratory infections in the future, perhaps even an impact on their life expectancy from having had the pneumonia and the ARDS, the acute respiratory disease syndrome that's associated with the pneumonia in this virus. Are there any other questions? I think that we had scheduled this for 40 minutes, and I think we might be at the end of the questions that people have. I do want to thank those of you who were interested in attending. We are looking for your feedback about these sessions, looking for what's the best time of the week to hold them, and also who you might be interested in seeing present with me when we get together. But it's nice to see you virtually, and I hope you're all well, taking care of yourselves, and having a good experience, either if you're teleworking with us or engage in online education with us, or both. But have a great weekend. I hope you have a great day. Take care. Bye.